Good morning. How are you guys? So let's quickly start another topic for Australian Dental Council exam. Why am I so excited? Because I like this topic, implants. This is something which I don't do. Because in children you don't do implants, right? But I always found it very fascinating, and I've referred tons of patients to implantologists, the parents of my patients basically. And it's just fascinating to see how the implant osseointegrates itself into the bone, and you get a permanent replacement for your missing tooth. But anyways, there are a lot of ifs and buts for the implants. And as a general dentist, of course, you don't get to place implants. So half of the things when you don't do, you actually don't think much about reading them. So out of you all, if anybody is a general dentist and who's placed an implant, well, you'll find this topic interesting. And for those who did not, I'll try to make this topic interesting. In future somewhere, I'm sure if you keep practicing general dentistry, at some point you will learn how to do implant, because that's kind of a standard treatment protocol nowadays to replace a missing tooth with implant rather than going for an FPD or an RPD, if possible, right? So let's start with implants. A very important topic because you always want your implant to be a success. So you have to make sure that the case that you are selecting has all the factors that would help you in putting the implant and making it a success. If any one of the factors is not favorable, then you can end up with peri-implantitis or an implant failure, which won't be nice, right, for you or the patient. So you should know when and why and where implant has to be placed, correct? So Implant from Wiley and Blackwell is the textbook that is recommended by the ADC resource. It's mentioned on their website. Obviously none of us have read this earlier, but I went, bought the book, read it, and I made MCQs out of it, or rather SBQs out of it, which are suited for the ADC exam, because these kind of questions are asked in the exam. They do ask you about implant. Of course, ADC does not expect you to do implant, but they expect you to know about implant, and they expect you to refer to the implantologist. But if you know how to do an implant, you are not stopped by the Australian Dental Council to give it to the patient. If you know it, you can just do it. I have so many friends who are general dentists who have learned how to do implants, and they are practicing very nicely in Australia. So if you know how to do implant, great. You can just straight away practice. There is no special license required for it. And of course, you have more business if you do implants, of course, right? So let's start. The reason I mentioned the textbook is that so you read from these particular textbooks only, as they are mentioned by the ADC resource. There may be wonderful other textbooks out there, but if ADC is not taking questions from them, then it's kind of a waste of your time, because we are strictly focused on preparing for the exam. So we are going to take the textbooks that the ADC recommends, right? Let's start with solving the question. The first question, a 55-year-old patient with a well-controlled type 2 diabetes seeks implant therapy. HbA1c is 6.8%. What is the most appropriate approach? Most appropriate. Like I said, whenever you find this adjective, it means mostly all the options would be correct. You have to choose the most appropriate one, correct? Now, you have to find the keywords from the question as well. Well-controlled type 2 diabetes. Well-controlled means the patient is taking care, he is taking medication. Though HbA1c is at a high level, but then he has diabetes, correct? And that is mentioned. But it's not like some uncontrolled diabetes that it's going beyond 10. It's a controlled diabetes. It's not uncontrolled, correct? So let's see the options. Implant placement contraindicated. No, it is not contraindicated. Delay until HbA1c is less than 5.5%. Well, if you want to wait till it comes down to 5.5%, it's basically non-diabetic, right? That's not going to happen. So you have to go with the factors which are controlled rather than trying to eliminate the disease. Proceed with standard implant placement and use short implants only. Short or long implants doesn't matter. You put an implant, you put an implant. So proceed with standard implant placement is the right answer here, because it's a well-controlled type 2 diabetes. If it was uncontrolled, then probably you should have waited until it is controlled, correct? Or you would have just not placed the implant for a while. But that is not the question here. Hence, my answer is option C. Which of the following is the least significant risk factor for implant failure? Least, again the adjective, which means all the options can be correct, but you have to choose the least significant factor. Smoking more than 10 cigarettes a day, oh well, that's quite a significant risk factor. Controlled hypertension. Controlled hypertension. Well, there is hypertension, so it is a risk factor, but it's controlled, so you can probably take that risk. Bisphosphonate therapy oral. See, that is also a significant factor, and I can classify that in the least format as well because it's an oral bisphosphonate therapy. But if I have to choose between option B and C, I would still go with option B because there is a risk of osteoradionecrosis setting in of the bone not responding the way I want to, because after all he's taking bisphosphonate therapy. But because it's oral, my risk is significantly less. History of periodontitis. Oh wow, that's a major contraindication. You need periodontium support. You want the periodontium to like the implant and it has to be healthy. If you have a diseased bone and gum, your implant is not going to stay. It will just end up with periimplantitis. So the most significant risk factor for me is periodontitis. Now you may question that the option doesn't say current state of periodontitis. It says history of periodontitis. So that option can also be correct. You get my point? So this option A I would eliminate, but option B and B, C and D are all for me in the same line. I mean, I can choose either of the option, but I still would go ahead with controlled hypertension because that is something systemic. That is not related directly to the bone, the jaw, the gums, and hypertension can be controlled, it can be eliminated. But something that is directly related to your bone and your jaw poses a little more risk factor than the systemic hypertension. Hence, though in my opinion, option B and C and D all can be correct, I would still go for option B with this thought process. Correct? It made sense to me, but you are free to choose your answer. A patient is edentulous in mandible and desires fixed prosthetics. Which bone assessment tool is best for implant planning? CBCT, straight away, close your eyes and go for it. Because CBCT is so accurate. It shows you everything in a 3D way. You can just slice off each. I'm sure by now all of you must have seen how CBCT looks like for any condition. Yes, it is difficult to maneuver the slices in the start, but as you get a hang of it, you start realizing, and it's great. You know, it's a very great tool. It gives you the precise location of the anatomical structures, the bone height, width, quality, etc. So the advent of CBCT, that is my answer. When CBCT was not there, people used to rely on OPG and periapical and occlusal radiographs. You know, they used to combine these three radiographs and then superimpose and just trying to make a 3D version of it. But since CBCT is invented, these things are out of the window. So yeah, hands down CBCT. The minimal vertical bone height required for a standard 10 mm implant in the posterior mandible is minimum. If you have more grade, but minimum, and your implant size is 10 mm. So see, this is a little bit of theory, there is no logic out here. At least 2 mm clearance is needed from inferior alveolar nerve straight away, okay, so that you're not impinging the nerve. And 2 mm is also so less, I feel, you know, it's such a deadly location, you know, you just don't want to touch the nerve and cause host of problems like paresthesia or severe pain. And by the way, just a fun fact, whenever you're doing an implant in the mandible, you never give a nerve block. You always give a local anesthesia, so that if you are actually impinging on the inferior alveolar nerve, the patient is gonna scream and you would know about it. But if you give a nerve block, then the patient will not be aware about it. So always you do implants in local anesthesia, never ever you give a nerve block. Remember this always, okay? So yeah. Now, question number 5 and the last question for today. A 63-year-old with history of osteoporosis is taking oral bisphosphonates. Now, this is very important, the keyword oral. because oral bisphosphonates don't cause that much of risk of osteonecrosis compared to the bisphosphonates which are taken via IV. Understood? So if you're taking oral, the chances of bone healing are more compared to if you are taking IV bisphosphonates. So you have a 63-year-old with an oral bisphosphonate for 2 years. What is the current protocol regarding implants? Current protocol, according to the protocol mentioned in the book, and this can be asked. They love to ask questions about BRONJ, MRONJ. Okay, you have to read those chapters properly from therapeutic guidelines, and you have to be aware of each and every sentence, because definitely 4 to 5 questions are asked on that. You know, there's not a single exam which has gone by without them asking any question about this. They love this topic, and it's true also because there are a lot of old population in Australia. Many of them are going osteoporosis, and many of them are on medications. So you should be well aware of how to treat this, because it directly affects your jaw. Correct? So what is the current protocol regarding implants? Answer is proceed with informed consent and standard placement. Implants are contraindicated is not right. You can give implants. Yes, there is a risk factor, but you can give implant. Delay by 1 year. Why? The patient may just keep taking oral bisphosphonate therapy for the rest of their life. So what are you going to achieve by delaying the treatment? Switch to IV bisphosphonates. Boy, you are not the general practitioner. You cannot decide to shift, first of all, them from any systemic medication or the root of it. And definitely IV bisphosphonates are more troublesome for you than the oral bisphosphonates as an implantologist, correct? So no, option D is out of the window. Option C, not applicable. Option A, no, it's not contraindicated. So even if you didn't know the answer, you could still reach the answer B. You know, the good thing about scenario-based question is that you should not get worried if you are confused between the options. If you don't know the answer straight away, you can analyze the other options and eliminate them. So whatever remains has to be your answer. And this is true for any sort of exam that you're going to give. If you know the answer, shoot for it. If you don't, eliminate the others. Shoot them also away. So then whatever remains is your answer. And most likely it's going to be correct, right? So we have solved 5 questions, and I'll see you probably tomorrow evening or day after tomorrow morning. Tomorrow morning I can't shoot a video. I have a case in general anesthesia. I have to get up early, go to the hospital and finish off that case, and yes, about that. So of course I look forward to your comments if you like the video, and see you. Bye bye.